Thank you very much, and thank you for giving me the opportunity to share my findings with you today. Right, okay. So why did I do this study? Well, I was aware that there's been quite a few small studies on bone health in children with EB. And what they identify is that the risk of osteoporosis in people with severe recessive dystrophic EB, which can lead to spinal fracture, is quite high. But however, what's written about adults, as one of the previous speakers spoke about, is there is really nothing in the literature about adults. The other motivating factor for me was that adults were really interested, wanting to maintain mobility, maintain bone health. This quote from one of my patients about how he felt about his reduced mobility and how it affected his quality of life. So the relationship is that spinal fracture, particularly in childhood, can lead to reduced mobility, but bony pain, all these factors are going to affect mobility and quality of life. So what are the risk factors? We've heard a little bit about this before. In a nutshell, reducing mobility and weight bearing, this is needed to stimulate bone. A small body mass index below 18.5 in the general population is identified as a risk factor in reduced bone density. Again, vitamin D deficiency, we know that patients quite sensibly are going to be protecting their skin, not wanting to get sunburn, not wanting to get overheated. Puberty can often be delayed in people who have more severe forms of EB, and estrogen is required for mineral accretion. Chronic inflammation can result in overactivation of osteoclasts and breakdown of bone. We've got nutritional needs, protein and calcium can be affected, and all this can result in bony pain, spinal fracture, and immobility. So, what do we do in clinical practice? We monitor alkaline phosphatase, which can be raised. If there's breakages, we monitor calcium, phosphate, vitamin D on a regular basis. In children, we look for spinal X-ray to actually see if there's been a vertebral fracture. We actually don't do this in adults, and this is something that from this study, that we're actually now thinking we really do need to do. As said before, we use dual energy X-ray absorptiometry DEXA scans to actually look at bone mineral density. We adjust them in children for body size, but in adults not. And we define osteopenia as a Z-score of -1 to -2.5, and osteoporosis as over -2.5. So, we began a longitudinal study looking at retrospective data, and our inclusion criteria were having had at least one DEXA scan between the ages of 17 and 35, and the patients needed to be seen by the MDT. We looked at the lumbar spine B&D Z-scores, and we put them at 5-year intervals so that we could actually compare DEXA scans at particular age points. So we could look at them over time and compare patients. We looked at calcium intake, vitamin D intake, the mobility score from the paper by Futrell, puberty attainment, and bisphosphonate treatment. Unfortunately, I can't report on all of those things today because there's a bit too many, but I'll report on some of the findings. We recruited 34 patients with recessive dystrophic EB, 17 female and 17 male. The age in the study in January 2015, the mean age was 31 and the range 17 to 47. 20 patients had got severe generalized recessive dystrophic EB, 10 had got intermediate, and 4 inverse subtypes. From statistical analysis, so we looked at the different age groups and whether they had puberty in relation to osteoporosis, body mass index, and mobility. We found that puberty was very strongly associated with delayed puberty in this age group was strongly associated with osteoporosis. Body mass index below 18.5, also a strong association. And mobility didn't quite achieve statistical significance, but still an indication towards it being statistically significant. Looking at puberty, a previous study done at Great Ormond Street by Moira Chung and Gemma Malario and Anna Martinez, they'd actually looked at a cross-section of patients and identified that the Z-score deteriorated with age. So in a group of 20 children aged 7 to 8, their mean Z-score was minus 1.8. By 15 to 18, it was minus 3.9. And they identified very much that they saw that as strongly related to puberty. So 84% of that group of children in the 15 to 18 age bracket had not attained puberty. Looking at our results, which I feel very, very much consistent with this, in our 16 to 20 age group, our mean spinal Z-score was minus 3.2, by 20 to 25 is minus 2.9, and by 26 to 30, the mean was minus 2.2. 80% of that recessive dystrophic EB severe generalized group had attained puberty, even though it was delayed. So what we were seeing was actually attainment of bone mass, but sometimes later. So we were able to give what I feel is a positive message to people that there was the potential for improvement. We also were very keen to look at why people walked. Tarek's talked a lot, very well about, the importance of podiatry and maintaining mobility. I was very interested to look at why people walk. We know there are physical reasons why people walk, but we also know that actually social reasons are very important for maintaining mobility. So from our notes, we recorded what encouraged people to walk more. So starting work, starting university or college, becoming a parent, even learning to drive a car, which actually meant the person was actually getting out more, were all identified as important factors. We also recorded the types of activity because we were actually looking to encourage people to be more active, and we ran a whole series of articles in the Deborah magazine about the types of activity that people actually were involved in to try to get people to think of things that perhaps they'd never thought of doing before, but they could actually embrace. And, we have some amazing types of activity, from Pilates to use of resistance bands to Nintendo Wii Fits, right? Summing up, very, very briefly, this gives an idea how, again, even in the severe generalized group, in some patients, bone mass after puberty did increase over time. Points of interest, as I've said, we found a number of factors to be statistically significant, but my big message is, and what's been good for our patients, is to know that it is possible for bone density to improve if people attain puberty and if they're mobile. And then people are more likely to mobilise if they're socially active. It takes a multidisciplinary team, our podiatrist, our physio, our doctors, our dietitian, and the patient at the centre of it all having a reason to be socially active. So thank you very much. Our job is to really ensure people can carry on being active and enjoy life. And thank you for listening, and for Deborah UK for funding this project.